I'm Rudy Zaragoza. I'm a practicing emergency physician, a telemedicine provider, and vice president for transformation for Vituity, which is the largest physician-owned and led partnership in America. And this is Kimberly Lopez. She is our director of psychiatry and neurology. And we're very, very happy to be here in front of you to talk to you a little bit more about who we are, who Vituity is, and what we've been doing in regard to telemedicine and efforts in said field. Something interesting about me is, probably the most interesting thing about me is that I know Milton Chen, the world's most interesting man. I mean, who would have thought he's hanging out with Navy SEALs in Afghanistan? Something personal about me is I'm married, I have 3 children, and I have a son who has perfect pitch, which means he can identify any note with exactitude, and he desires to be a concert pianist at Juilliard someday. So an overview of Vituity. We are a physician-led and organized partnership. We have been in practice for over 45 years. Last year we saw about 6.3 million patients, and then by the numbers we're over 2,200 physicians, over 1,400 advanced providers. That includes nurse practitioners and PAs. We have 2,000 scribes, which makes us the second largest scribe company in America. We saw about 6.3 million patients last year, and we're on track to see about 6.8 million patients this year. We underwent a name change earlier this year from CEP to be a little more inclusive of all the different practices and practice locations that we currently reside at. So as you can see from here that though we originated from an emergency medicine practice, our practice lines have really expanded to something very diverse. And you can see here that although we are firmly committed to acute care, a post-acute care space, and to urgent care populations, we've now branched out and are participating in psychiatry, neurology, hospitalist medicine, intensive care, general surgery to include robotic surgery, telehealth, post-acute care, outpatient medicine, and of course, EM. So although we're in 15 states, the majority and bulk of care that we deliver is here in California. And last year we saw about 4 million patients, and we're the largest Medi-Cal provider in the state. Part of our evolution as an organization has been to develop a strong focus on telemedicine, and actually to develop our own platform with the help and collaboration of VSee. VSee helped us create a very user-friendly and efficient platform that was able to be co-designed by our physicians for multiple use cases. And currently, we're using On Duty for these mentioned practices. So with telepsychiatry is our fastest growing practice, and this year was endorsed by the Hospital Association of Southern, Central, and Northern California as the telepsychiatry platform of choice by providers. Teleneurology includes the integration of teleneurology, telestroke, neurodiagnostics, and remote monitoring at over 35 hospitals. Tele-skilled nursing means that we're able to kind of beam in and be part of the care team at a skilled nursing facility. And this allows more patients to be cared for in place. It elevates the level of care, and it saves money by keeping those patients in the skilled nursing facility as opposed to being sent unnecessarily transported to the ER, and also decreasing hospital readmissions. Telecritical care allows us to take care of our sickest patients in the ICU and in vented facilities. And then tele-urgent care allows us to take care of patients both in clinics, sometimes at FQHCs, or in their homes through an employer-based model. And then finally, teletransitionalists means that we're able to manage patients outside of hospital walls through the help of patient navigators and providers. And I'm going to now turn the microphone over to Kimberly Lopez to talk to you more about telepsychiatry.
Thank you, Rudy. Yeah, so like Milton said, my personal goal this year, actually it's not just my personal goal, to me and my 9-year-old's goal is to adventure through all the Major League Baseball fields by the time he's a freshman in high school. So we have about 3 years to accomplish it, because I know once he becomes a high school student, I'll probably never see him again. So I'm a mom of 3. I'm an RN by background. I started as an emergency room nurse, and through my work with Vituity, I was able to get more involved in our psychiatry and neurology practice line. So about psychiatry, telepsychiatry, so it offers a lot of benefits to the hospitals and the patients. It's not like you would think about when you go into a site that needs tele services. We're going into hospitals that aren't in rural locations. We're being asked to see patients in high populated areas because the low availability of psychiatrists out there and the high population of patients. Historically, psych patients will sit in an emergency department up to 2 days before they could get seen by a psychiatrist. The length of stay to get a disposition could be as long as 4 to 5 days in some of these locations where psychiatry going in, we would see. So, we're starting to see improved quality of care. We're getting patients started on treatments, earlier interventions, decreasing length of stays in emergency departments, increasing discharges from the emergency departments to the right locations instead of the historical area behavioral health patient that enters the ED automatically needs admission to a behavioral health unit. We're eliminating that and getting the right patients to the right place at the right time. So telepsychiatry, so it's been it was a slow growth. Milton mentioned earlier, 90% of startups will fail. We definitely had that feeling for the first couple of years is what are we going to do? How are we going to overcome the hurdle to get into more locations? So when we started at our first site in 2016, this is when we were really partnering to develop the platform, to develop a documentation tool for our physicians to not only schedule appointments, to have a platform where they document their full assessment. How did it integrate into a site's EMR? How did the nurses reach out to us to ask for an appointment, to get the appointment scheduled? And then how did we work with the sites to educate them on this is how you turn on the computer, this is how you set up an appointment, get a patient ready to be seen by one of our telepsychiatrists. So throughout the course of the time, we overcome the hurdles, IT security assessments, logistical issues that we got turned down. We got told, no, we don't pass those security assessments. But we worked through it, developed workflows, and successfully partnered with sites to where we're now in 2018. You can see our substantial growth. We're now at 12 hospitals, both in inpatient settings as well as in emergency departments. Where our average daily census was in the negative, we're now seeing about 26 patients every day. And the benefit of all of this is it's the right thing for the patient. So as I mentioned earlier, treatment recommendations, earlier patients being seen by a psychiatrist, and with that, 37% of our patients that we see that come into one of our hospitals on an involuntary hold, our telepsychiatrists are able to recommend disposition and get the patients discharged out with resources or prescriptions. So one of our case studies is we get asked a lot, what is the value of bringing in telepsychiatry services? We have an administration hearing, yes, it's very valuable for the patient and improves quality of care, but there is a cost associated with it. So what is the overall value? So when we talk about ROI with our administration team, the first thing we talk about in emergency departments is the decrease in length of stay, how that calculates out to, getting your lefts without being treated into a bed, reducing sitter hours, nursing hours, whatever it can take to show that value. Additionally, we talk about the decrease in transportation. So a lot of times hospitals are transferring from EDs, paying for ambulance transports, going to an inpatient behavioral health unit, when really they just needed to be seen and discharged, so that cost could have been avoided as well.
So in closing, we're working very hard to bring telemedicine as part of a central part of our organization and to have it touch as many lives as possible. We're always looking for innovative ways to use technology and to introduce telemedicine to help patients navigate the care continuum, whether that be going from the emergency department to the home or the hospital to the skilled nursing facility or the skilled nursing facility to elsewhere. One of our most recent innovations was mentioned yesterday, in that we are this year going to be utilizing Telehealth as part of the new paradigm of APM, so alternative payment methods. So we will be participating in a CMS BPCI A, which is Bundled Care Improvement Initiative, if you will, advanced. What that means is that we will be participating in a CMS program with the aim of reducing cost, by which we are going to put responsibility on the physician care teams to reduce the actual cost of the bundle of care. And also we're going to be focused on care team redesign through early engagement of the patient, collaborative communication, and post-acute care navigation. So that being said, it's a pleasure to be here amongst so many interesting people and innovators. Thank you so much.
For some questions?
So in your post-acute care navigation, what do you include in that, and what is the meaning of that, actually?
So what that means is patients will be, this includes the patients admitted, this includes patients that were admitted in a hospital stay. So after the discharge from an inpatient stay, we become responsible for the care, for the cost of care that was delivered during the inpatient stay and 90 days post-discharge. So how are we going to do that? We're going to do that a couple of ways. We're going to utilize a patient care navigator who's going to be a touchstone for that patient. If the patient has an issue, it may be transportation, it may be non-clinical, they can call the navigator. If the question is clinical in nature, then the navigator will reach out to a transitionalist who's a medical provider. It could be an advanced provider, or it could be a physician who's on call who will reach out to the patient and help them with their either clinical dilemma or answer the question. The idea would be, does this patient need to go right back to the hospital? Probably not. Is this an emergent issue? Is the patient sick? If so, then they go back to the facility, and that didn't work. But if it's something that could be managed either by, merely by having them see their primary care doctor, answering a question, prescribing a medication, in which case that way we'll be able to intervene and help control costs. But the big part of this is really taking responsibility for care for 90 days. It's a lot to ask, and utilizing innovative resources to make it happen. So it takes a lot of interconnectivity and collaboration to make this successful.
For your emergency room telepsychiatry docs, how do they know, usually ED visits are after hours, how do they know where to divert patients to, or what resources are available for the patient?
So, our telepsychiatry services are 24/7. So usually we partner really closely with the hospital. So pre-implementation, we'll work with the sites, we'll talk to the social workers, we'll talk to the PERT teams as needed to really get a feel for what the outside resources are when we're making those recommendations. And then we always do a handoff. So once our physicians see the patient, we get on the phone with the emergency department or the social workers as needed and talk about that handoff and partner together to create that disposition plan that's appropriate.
Any other questions?
A quick question. Are you also into tele-ophthalmology?
Not yet.
Let's talk.
Let's talk.
Any other questions? Okay, can I ask you a question? So you guys do work with so many different hospital healthcare systems. So if you engage with hospitals, if they're not, even though telehealth is really good for them, but they're just very, really slow. Maybe it's almost compatible with the previous speaker about, is there any tricks you guys do or things you do to help them embrace telehealth a little bit faster?
We've seen it just, showing the metrics, showing how it impacts patients and quality of care is one thing, just getting our foot in the door to say this is the right thing to do for our patients. And then really just partnering with them. We work very closely with their on-site IT security teams who typically have the most questions. How is this HIPAA compliant, which it is? Is data going to be stored anywhere else? It's not. So building those relationships and that trust, scheduling demonstrations. So I work closely with Lauren, who will get on, do a demo of the product, and really showing. Your team's been on calls with me in the past where I'm like, show them how this works, help turn on the computer. So just having that overall partnership really goes a long way.
Awesome, great. Thank you so much.
Yeah, thank
you for amazing.